Okay, so again, today I'll be talking about how our group or how some of the programs here are attempting to integrate geographic data science into public health policy. I should note that I will sometimes use the term spatial data science. And it's hopefully it's no offense. I kind of use the terms interchangeably, but that's a whole other discussion. But first, I wanted to talk a little bit about the motivations of like why I do what I do, and some of the kind of components that drive our lab. So we know that maps and visualizations have a long role in public health. I highlight two here. So this is the famous Menard Map by the French civil engineer on the left. On the right-hand side, we see Florence Nightingale, a statistician and nurse, and a diagram of the causes of mortality. So a really nice rose diagram. I wanted just to kind of elevate both of these two because while they're gorgeous visualizations that have quote unquote stood the test of time, they come with a very specific motivation and purpose in mind, where obviously these are the kind of finalized cartographic products that went through a lot of iterations along the way and also had really specific goals in mind. In both cases, kind of communicating the harms of war specifically. So some of the things I might speak about today in this, my part of the lecture may seem a little bit political, but I wanted to, again, kind of build on this tradition of scientists doing work to kind of advance justice in general. Another, I mean, infamous or famous, I can't believe I said infamous, famous example, the Jon Snow, a really classic example of integrating maps into public health. One of my goals in my life is to visit that Broad Street pump one day, which I'm sure is a super touristy thing for, for you guys who are based out of the UK. But here I wanted to highlight and elevate some of the recent work by Thomas Coleman and Julia Kaczynski that have really kind of looked at the history of the research design and process of Jon Snow. So this map was not the first map to identify this problem, it was actually one of the final, this had followed, a long period of research by Jon Snow where he was trying to advance a certain hypothesis of, cholera as a vector-borne disease through water rather than air. So this map was actually, following a much broader story intact. And so today, in the kind of modern public health environment, there's been a big shift from a focus on just infectious diseases to kind of chronic diseases, and then the confluence between. A lot of this has moved towards thinking about health as the social determinants of health, which are defined as the physical, social, environmental conditions in which people are born, grow, live, work, and age. From some of the research things I do work on tries to actually quantify what that is, because that's a huge quantitative challenge, and there are dozens of different models, competing models, conceptual models of how to define social determinants of health. A lot of them are conceptually driven versus data driven. Some do a mix of both. But there's a huge quantitative challenge here because obviously work and education cannot be seen as intrinsically separate when we work with the data side of things. But beyond that, one of the big pieces here is now we know without a doubt that more than half of any individual's health is more linked with where they live and kind of these contextual neighborhood environmental factors. The actual genetics that were for a long time kind of focused on as the primary focus of health, that's at least 50%, if not less, more likely 20 to 30%. Obviously, I won't go into epigenetics or anything like that, but that's why I think public health has really opened up to social scientists, geographers in a way that we haven't seen for quite some time, which is exciting. And interestingly, there's kind of these interesting connections that are almost causal or deterministic connected to location, which could be problematic. So I hear this type of speech a lot in public health. So the most important 5-digit number I need to predict your health status and well-being is your zip code, right? So insurance companies use aerial codes to drive or help determine health insurance rates or car insurance rates, at least in the US. But increasingly, this existence of these correlations are so strong that they're being used in predictive modeling. However, there's a lot of challenges that emerge from this, that the traditions of geography and kind of spatial data science from decades are informing this, right? So spatial effects impact our research in multiple ways. We know this. If it's not considered in the theory, for example, if we assume a 100% deterministic perspective that where you live is actually directly, determining your health, we may actually confuse the processes being studied, miss important signals, and violate core assumptions, right? If you move to a different location, your health doesn't suddenly change overnight, right? There's complex processes that are driving the spatial heterogeneity that we see. If we don't include spatial effects in the methods, it skews or biases the results that impact decision making. I love hearing the gasps of colleagues from kind of traditional epi fields when we first talking about spatial regressions, or how spatial autocorrelation may actually violate the statistical frameworks they're working with, right? So these are things at the population level that as there's more momentum in this area, there's a lot to be kind of collected across both ends. And then finally, if we don't include the spatial effects, it impacts the technological infrastructure, where a lot of folks may not even think of integrating data on place or time, or do certain types of analysis or dynamic results. So before kind of diving in, I just wanted to take a couple slides to talk about some of the opportunities or challenges and questions that have emerged in this space. So there are so many opportunities for spatial thinking in public health, and so I can't emphasize enough how more, like, we need more folks from this field to kind of cross over, right? So there's a lot of really interesting research that could focus on distilling exposure versus vulnerability as drivers of differential health outcomes. So this shows up in COVID. It will also show up in air quality research, how exposure to a pollutant or to a virus exists as a separate concept from vulnerability to pollution or vulnerability to the effects of a virus. So there's a lot of really interesting work there. And again, focusing how spatial effects are not just one idea, but they manifest through multiple processes. Extending that further, there's a lot of opportunities for connecting spatial and social networks to better understand syndemics. And so syndemics might be, for example, how, so I do a lot of studying on the opioid epidemic, but there's, that actually includes studies of HIV, hepatitis C, and other downstream infections. That is because if individuals shift to needle use, so drug injection use, there are all sorts of downstream fallouts from that, from increases in infection to infections individually, infectious diseases across persons. So how all of those things work together, it necessitates thinking of activity spaces, risk spaces, and so on and so forth. In public health, there still really needs to be, and this is slowly have been gaining steam, but the acknowledgement of the existence of spatial heterogeneity. So COVID is not the same everywhere, and there are really interesting complex reasonings for that. And we can use the spatial signals of place and the demographics and then the history that kind of drove those processes to emerge in the form that they exist today, to understand and contextualize the spatial heterogeneity of the outcomes we see. Another huge piece is linking causal inference with spatial effects to understand the roles of place and policy throughout this. And then finally, engaging emotion in human perspectives and cartographic processes. I was very not interested, I guess, in this perspective for quite some time, but working on the COVID Atlas project has totally transformed how I had previously undervalued this aspect, and how this is, sometimes data is not enough. Facts are not enough. We need to think critically about that communication piece. So essentially, I study in, as the PI of the lab kind of studies, how does place impact health in different ways for different people? While we study social determinants of health, I again want to be careful around that term determinants. It's we might want to think of it also as social, reinforcers of health or magnifiers of health, because there are different processes driving that. So we use a variety of techniques and open science tools to investigate issues of equity across space and time. And the focus is always to always in the back of our minds, seeking policy-driven systems integrating solutions. And then what does that mean, right? Like what are the ways in which research are shaped for policy translation? We're not a pure policy group. We're essentially a geography-based group, but are interested in translating that to policy. After a while of working with different community organizations and different levels of government, from city government to county levels to state to federal, I've learned a lot along the way of we really have to think about what questions do we ask, what approaches do we take, linking something that is very novel and nuanced in the research field may not actually be that useful or needed within the policy work, right? And that's fine, but in our group, because there's this commitment to link the two together, we're always, there's always this tension of, we want to remain a research focused group, but also do good space in the policy world. So what this means is actually doing things like, well, we can actually link conceptual models that are driven by the theory and understanding of, decades of research with quality statistics that have rigorously thought about each phase, and then use those for pragmatic applications. And then along the way, when the questions are being asked, it's not just the researchers in isolation. There's a lot of work being done where we're interested in asking questions with the people that we're actually building the systems or doing the research for. And this happens in many different ways, but and this can be a huge shock to groups who may community organizations who are not used to researchers actually asking them what they need, searching for the wisdom that they have to offer. So there's a bit of a hierarchy breakdown there, but I think in a positive way. And then the other piece is, Julia Kashinsky at the center always talks about like why do we care? Why should we care? And that's important. Elevating that justification, and then also thinking about from a policy application, like where is the need? That becomes a very practical extension of anything we do. So systematically working on considering, social, racial, health, and spatial equity. Sometimes the focus might just be detecting patterns with exploratory data analysis. I say just, that's actually a huge, like the COVID Atlas is essentially that, and it's very complex. So the process of exploration is not to be devalued. But then other times there may be an interest in actually evaluating within a causal framework. And then of course, developing systems and structures to help access data research insights. That ends up being a huge part of what our group does, because oftentimes community organizations and governmental groups don't have access to the data and research in the way that they need. So asking them that, it's funny because I've working with an air quality project recently. There's been all this phenomenal air quality work done, and we were trying to connect that existing research and data with the different groups. And the researchers were like, "Well, we published our code, so they can figure it out." But I can tell you right now, it's not very easy for community organizations or government groups to just pick up the code and replicate something that might have taken years to do by a research group. So we have to think more critically about what openness really is. And here is, so there's I was going to add this. Okay, I'll do that in a second. So a lot of this actually is when we're thinking about these things, it's become really apparent as similar themes emerge in the research that we do, especially in the US over and over and over, that we really need better conceptual frameworks to actually organize the thoughts before we even apply the data science paradigm and spatial analytic approach and that sort of thing. And that's increasingly, so in health geography, there's a tradition of political ecology. In HIV, hepatitis C literature, there's emergingly a tradition of risk environment frameworks, which combine kind of critical theory work with quantitative. But we found that in public health, it's, those are broadly, none of those have been broadly adapted. And sometimes it's because of the difficulty of jargon, where in some groups, they're happy to talk about neoliberalism without any qualms, but in a governmental organization working with multiple community groups with competing interests, that may be neoliberal, that term may be pushed away rather quickly. So I'm seeing kind of our group is kind of in the middle between these two groups. Long story short, we found that intersectionality as a framework really may do a phenomenal job in linking some of these pieces together. So I'm not going to give a primer into intersectionality because I'm also not qualified to do that. But broadly speaking, intersectionality is a conceptual framework developed to better understand how systems of oppression intersect, interlocked, and reinforce one another to produce disparate experiences, outcomes for a variety of groups. You'll note here the parallels with social determinants of health and where we are in public health right now. And from a geographic perspective, I mean, this makes sense. I want to propose a new function of ST_intersectionality that would be used to kind of integrate some of these pieces. So our lab has spent a lot of time thinking about these things in the last year. We had a book club about the black butterfly, which talks about some of these nuances within the United States. I'll just leave that that as one aspect. We also some of us attended a great talk on data feminism, which is specifically the whole concept of that text is integrating intersectionality into data science. And again, we'll also be having so this is an area of ongoing work. And again, this is just to kind of organize how we think about what we're studying, and then also ensure that how we're studying it is not making any of the injustice or inequitable outcomes worse over time. And then just to bring in a different kind of geographer, so Lipsitz talks about how the racialization of space and the spatialization of race exists. I like to use, I highly recommend reading this. So sometimes I'll have more difficulties talking about this with quantitative researchers who focus on the individual and like social network scientists and that sort of thing, because they'll talk about how, space, place, all of that doesn't matter. It's all about the individual. Well, it turns out that there are all these structures that exist that enforce segregation at neighborhood levels. So redlining, legacies of slavery in the United States, a lot of different complex processes, right? So the lived experience of race has a spatial dimension, and the lived experience of space has a racial dimension. These things are really important when, again, noting how spatial effects can manifest in different ways. The racialization of space can exist in different ways. So institutional versus interpersonal racism are two different functions. And as a geographer, I'm trying to think about that as two different ways of being quantitatively modeled, right? So I'll just kind of stop there, but the idea is how can we thoughtfully, meaningfully, and appropriately integrate more rigorous conceptual frameworks like intersectionality to underpin, drive, and challenge GI science methods in public health research. I know there's some folks in your group who've also been talking about this that we include in our readings. So our group will be hosting a symposium in May. Feel free to check that out if you're interested in participating. But that being said, with that framework, our group is attempting to tackle a lot of different topics that may seem very disparate, but when you kind of come at it from an intersectional perspective, it's actually a lot of the same outcomes throughout all these different topics. So, for example, how and for each of these topics, how we research it may be similar, but then the policy translation could be very different according to who we're working with at the time. So one project that's will be coming soon and for the professional geographer was measuring how the Great Recession impacted food access. This was more of a causal inference analysis to kind of fine tune an understanding of the spatial effects that were occurring. The policy translation here is more the traditional perspective of, it's more about the article itself than anything else. We found that areas at greatest risk of food insecurity during the recession were more likely to experience a compounding crisis of structural racism and economic vulnerability, but then this really complex methodological framework to show that, right? But sometimes we all will have policy translation that is much more complex. The questions may be a little bit more straightforward. And that, there's no causal inference analysis because of limitations of data, but here the heavy lifting may actually come on the other side of things. So we've also been working with the Chicago Department of Public Health to understand what air pollution looks like at the local scale in Chicago. This started off as a really, simple project where we're working with a group on low-cost sensors who had installed low-cost sensors across the city. And the idea was, let's model that. Let's see if those sensors can, improve air pollution estimates. The short answer is the quality was not sufficient for a number of complex reasons. So then it shifted to something slightly more complex of let's estimate small area pollution using statistical machine learning frameworks. And that has then spiraled into, well, we could probably do better with spatial econometric models. That's the research side. From the city side, they're interested in, so the common question is, well, what communities are most exposed to and most vulnerable to particulate or fine-grained particulate matter, which is the main pollutant we're studying. And that's actually a different question, right? And it turns out that we found a lot of communities that had the highest exposure to air pollution were actually not the ones who were the most vulnerable to it. However, the asthma outcomes and some of the chronic health conditions tended to be more around areas with higher vulnerability, right? And then this comes back to that intersectional understanding of space. Well, that's actually because of long legacies of community de-investment, racism, and so on and so forth. In this project, the policy translations are essentially a bunch of tools and infrastructures. So we developed data, small area estimates that was put on their website. We have been prototyping interactive dashboards to explore not just the air pollution, but all the covariates and drivers of air pollution across time. There's another site selection tool where that was useful, but the group wanted some things slightly more operationalized for decision making. So there's another kind of selection tool that's come out of that. And then finally, we have in our, it turns out that doing all of this, we're not satisfied with the existing kind of pedagogical infrastructure for how to work with all these different types of air quality, air quality drivers. So we've been developing a toolkit and kind of an open source book that goes step by step for how to work with this data, how to translate it between different scales and so on and so forth, so that other cities in the future don't have to do the whole thing all over like we did. But then what you guys are here for, and I'll just talk for maybe 5 minutes about this and then pass it over to Dylan. But what we've really been zooming in on in the past year is the COVID pandemic. And interestingly, a lot of the challenges with the COVID pandemic it became really clear what some of the technological, methodological, even theoretical pieces were from the past work that our group had done. Right. So at the beginning of the COVID pandemic, our group had been closely watching that as We have connections to Wuhan University as well, where they have some of the world's best C coders. So there's actually an exchange between groups at some point. But at the very beginning of the pandemic in the United States, it became really clear that there was a lack of publicly available county level COVID surveillance. A lot of the reports and analyses were at the state level. And as a geographer, we know that that's very problematic and may miss maturing hotspots, right? So a hotspot would have to be massive in order for this whole state to emerge as an area of concern. At the same time, a lot of the existing tools that were out there offered cross-sectional views and static maps. So just snapshots at one point in time, which because things were changing so rapidly day by day, week by week, we needed more. A lot of the other aspects too were that not all groups could access sophisticated spatial analytic tools. I wasn't worried about Chicago. I wasn't really worried about New York or LA, large cities that have a huge, clustering of bright, analysts and geographers and a lot of different groups. But what about everywhere else? Because of the fragmented federal landscape and huge, not even comparable, huge inequity between urban and rural spaces, huge swaths of rural America just would not have the same access to the data, would have a completely different set of information that was being communicated towards them, and then a vastly under-resourced analytical landscape to understand this. There's also multiple data sets of COVID from multiple sources. And then because there's an interest in integrating, community factors for quick, applications, that is have worked with government groups and or community groups in the past, that's not something that all groups can do very quickly and easily. So we developed the US COVID Atlas as a clustering, surveillance, and data visualization tool that would provide quick access to county level COVID data and statistical cluster detection. This is really developed as a research coalition led by UChicago, but with many other groups. And staying true to our roots, everything had to be open source and open science. Here's a snapshot of some of the data involved in one of the co-PIs, my postdoc, Chinwing Lin. This data set is probably, you can see COVID health outcomes, testing, vaccination from multiple sources. We have our own insights like statistical hotspots, cold spots using the LISA, local indicators, spatial autocorrelation, different types of choropleth maps with actually readable bars, severity index from Berkeley, which was another group. So our goal was not to just leverage our research, but create an infrastructure where other research indicators could also be linked into. Working with groups at the very beginning, we knew that health systems infrastructure were really important. So over time, adding a lot of those kind of aspects. And then finally, the intersectional perspective, we know social, economic, and environmental aspects really matter. So we actually worked with the county health rankings group who they specialize at the county scale. I usually specialize at the neighborhood level. So I didn't think I was clever enough to immediately know what were the best indicators at this more macro level. So we collaborated with a group who did. And then Chiming here she's kind of the lead of data, what's included, what's not included, and wrangling all those pieces. What you see here at the bottom, so this was the group that started. So myself, Chinwing and Xuan. But this group has grown considerably since, and at least for a while, the methods that were being included were choropleth maps at multiple scales, natural breaks, Jinx box maps, statistical hotspots, temporal sliders, interactive exploration, linking that in with new cases, time graphic, and cartogram. I won't go into the details here because you can see all of that on the site, but I do want to just draw your attention to what these three maps are showing. At the beginning of the pandemic, again, there was really a focus on statewide analyses. At that top map, you can see that Illinois is flagged as a hotspot, and the other two circles are not. As soon as you switch to a county level view, however, it turns out the Illinois hotspot is really Chicago. The Arizona and New Mexico, there is tribal, several First Nation groups living on tribal reservations that had extremely high COVID rates. That was completely smoothed and averaged out when you aggregated to state level. So that was missed from a lot of media attention. And then finally, there is this cluster of very, very high COVID rate counties across the South through Mississippi, Alabama, and Georgia that were also completely averaged out when you did the state level. And then the LISA map at the very bottom just kind of filters at that extra extension where you can clearly see that they are not just artifacts of our minds that love to see patterns, but actual hotspots. Who is the COVID Atlas for versus who uses the Atlas are two different questions. They started off as the same, but they've been diverging and we've been constantly shifting towards that. At the beginning, the COVID Atlas 4 were really for health professionals in under-resourced areas. So we had linked with rural health network practitioners across the country and a lot of other groups who needed it for that reason. But it turns out over time, the public was really interested in the Atlas. Journalists were using it. Researchers were using it to do exploratory analysis on their own. Teachers were using it to teach the pandemic in their classes. And moving forward, we still kind of are always, Dylan will talk a little bit about this probably in his demo, but these two questions are something we're always trying to stay on top of, but also continue to shift over time. I won't go into details here because this would be a whole other talk, but essentially the Atlas is powered by an inverted cyber infrastructure that is building on decades of work on Geoda and related open source modules. So Schwinn here is really the architect that started the whole thing. And then Dylan, as you'll be hearing from, has recently kind of refactored this into modern React JavaScript framework. But a lot of this is working on a JS Geoda WASM. I don't know if I'm never saying that correctly, WASM module. Long story short, the calculations are not being done on a server. They're actually being done on the fly in your web browser. So when you open up the Atlas, you're essentially bringing all the power of those base C libraries into your system. We also have a shared and managed data integration system with a lot of different great folks who continue to kind of fine tune and manage that. And the goal is to, whatever data we grab, we're also finding ways to kind of push the cleaned products that we work on back out to the community. And so again, atlases are curated collections of maps and data. We see this in contrast to dashboards, which might be just a quick at a glance overview report. Our goal is to provide a more personalized, in-depth experience that considers uncertainty as a feature, not a bug. So including multiple data sets to show how variable the outcomes will be in multiple perspectives and design, and then a participatory design approach where we've constantly been working with groups and communities and users over time to make things better. And then the other part is really translating these insights into a variety of ways. We are working with artists, graphic designers, librarians, a lot of community members, a pastor, and many advocates to do this. Because and also working on journal articles. But as a goal, our lab has decided to make sure that our own research incentives are at the last of, they're important, but it's more important to get this work out in a way that is meaningful for the wider community. We have found a few insights along the way. So Moksha did a really nice kind of mini analysis. Our group was one of the first to identify vulnerability in rural areas in early stages where there was a lot of focus on cities instead of rural areas that have a huge amount of compounding risk factors for COVID rates, like less hospital infrastructures, more vulnerable groups on average, older groups, and a lot of, even though people live further apart, they love to congregate as groups. That might be, you have to be from a rural area to understand that potentially. And then we also had kind of found that cluster of counties ended up being essentially the Black Belt. So bringing in the Black Belt, and these are areas that are majority Black or African American, and have a legacy of racism and slavery in the US, and have not been invested in for, I mean, over 100 years, essentially. So unfortunately, unsurprisingly, some of the earliest rates were also along this stretch of area. We've done a lot of, tracking of unexpected hotspots like spatial spillovers between, states that might have competing policies. And long story short, COVID is really a national story with a local experience. The law of averages creates a lot of challenges for exploring COVID. I'll kind of jump through some of this here. Let's see. And because I want to make sure that Dylan has a chance to talk about what he's doing. I'm going to stop here, Dylan, if you want to switch over to yours.
Perfect. And okay, let's see if we have a smooth transition. Can you all see my screen okay? Perfect, okay. So I'm just going to walk through here just a little bit of what I've been working on with the team. So there was a whole lot of work done on the COVID Atlas as sort of a front end and as a data platform long before I joined the team. So I came on in November. And what I've been working on is sort of taking all the incredible work and design that's been done and taking that thought and sort of pushing it to the next level. So part of what we've been doing is refactoring into the React JavaScript framework, as well as adding some new features to give even more fine-grained controls. So the COVID Atlas as an interface really aims to be flexible, to be fast, to be transparent, and to be interesting and engaging to use. So I'm going to give a quick walkthrough of the different parts and the features here, and then give a little glimpse of sort of the tech behind it, and then kind of what we're working on now and what's coming next. So most of the controls for the map and the exploratory data analysis live in this sidebar. So we currently have 15 variables, which range from cases to deaths to testing information, vaccination, forecasting, and community health information, community health context. On deck, for things that we're going to be adding soon, we have some mobility data, which is based on the SafeGraph data set, which is parsing out by county what share of devices are categorized as being at home full-time throughout the day, at a workplace for 6 to 8 hours, which is kind of a full-time behavior, and then at a workplace for 3 to 6 hours. I should say for most of these data sets, they're available across time, most through the end of January 2020 through today. These are updated daily, so near real-time data on all of this. To complement the mobility, we're also adding essential workers, which this is going to give a little context to why people in certain areas of the country may be required or choosing to leave the home. And then additionally, we're exploring some hospital bed utilization for some point data, as well as longer term, we've been exploring policy data to, again, really contextualize what was happening, where, and when. So as Marynia mentioned, no single data set is authoritative, and even this week, we're finding artifacts across the different data sets of reporting inconsistencies and how different data sets are tracking over time. So for each data set, we try to provide as many sources as possible. For the deaths and cases, right now we provide 1.3 acres, USA Facts and New York Times. Soon we'll be adding CDC for this, as well as the Johns Hopkins data set. So we really try to give multiple sources to show that there is some uncertainty in the reporting. Next, we have some customization in the date range. You can select either a daily new, a 7-day average, the cumulative count, or you can set your own range. So if you want to see a monthly view or a 2-week or 2-month, you can pick any time range that you would like. Additionally, a lot of the variables have geographies available, either a county or a state level. And for some, we'll be adding some point data. And then lastly, there's the binning reference. So you can either reference the color bins based on the most recent date or whatever date you're looking at. So have them changing dynamically or statically. So last, I'm going to walk through what these look like. We have different map types. Like Marynia mentioned, we have the natural breaks or JANKs, we have the box map, and then the hotspot, which is the spatial autocorrelation, as well as 3 visualization options, being a 2D, 3D cartogram, and then a few overlays and resource layers. So here we are with our choropleth natural breaks map. These bins are calculated on the fly, as Marynia mentioned, using the JS Geoda WebAssembly module. So we can look at this map also as a box map here with the lower outliers, the different range bins, and then the upper outlier. So this helps to sort of clarify and summarize the data. And taking that even a step further, the hotspot map really shows you which areas are high rates surrounded by other high rates, and then the opposite, cold spots being low rates surrounded by other cold rates. It's important to note here, of course, that these are relative to the sort of universe of the lower 48 of the United States. Even the cold spots can be quite high. So going back just to the normal map, so we see this is a 2D view, fairly typical. We have some kind of cartographic elements of a little bit of hill shade, a little bit of water overlay, but we can also take that into a 3D view. So this really helps to kind of reinforce the values that we're seeing. The z-axis is scaled to whatever variable you're looking at. This can also be animated over time, so you can see the county boundaries going up and down over time, so it makes a nice animation option. Lastly, there's the cartogram option. So this does a bubble style cartogram scaled in area based on the values. So again, sort of reinforcing the color scale that you're seeing with the size of the text and of the bubbles here. So the next piece is the overlays, and this is really trying to add context and shine a light on areas that have historically been under-resourced by existing power structures, and areas who continue to feel the painful histories of colonialism and racism. So here we see Native American reservations or First Peoples lands, but we also have available views on hyper-segregated cities, Black Belt counties, which is that area across the South, and then US congressional districts, which is can be an important piece of context, particularly as we were in the election back in November. Lastly, we have these resource layers, which are meant to kind of reinforce or illustrate what the health infrastructure looks like across regions. So here we're seeing both clinics and hospitals. The clinics are the federally qualified health clinics that are the green triangle or green diamond, sorry, and then the red crosses are the hospitals. So there's also a material use here in that you could use this to find a testing location by hovering over, and you can find information about that hospital or that clinic. We're also hopeful that in the future, we can use this for finding vaccination sites as the wider vaccine rollout moves forward. So last couple of pieces here in the interface. On top, we have a time slider, which as you imagine, you can change the time. This is one of the really unique features of the Atlas is having a very fast and very robust way to look backwards and forwards in the time scale of the data. And then you can also click that play button and it'll automatically animate through the available data. To the right, there are a couple buttons to toggle off these floating panels. So we have a floating panel, which is sort of in the style of like an R-Shiny floating module that has the line chart, and it's biaxial, showing the total cases with that white line, and then the 7-day average of new cases in yellow. Additionally, you can swap this between a linear or logarithmic scale, and this can be resized, moved, or closed. Additionally, the information icon will bring up a built-in manual, which gives some description of the variables and run through the interface. Down below, you have the color bins, which will respond based on which map type you're using. So one other unique feature here is that you can aggregate counties or states on the fly. So here, by either holding down Control and clicking multiple counties, or holding Shift and then dragging a boundary, you can select multiple counties. And so here we have 4 counties selected in South Carolina, and they're all added to the line chart, as well as on that right data panel, we get a lot more information. So the panel on the right has information about cases, deaths, and population, as well as a lot of important community health factors, things like children in poverty, income inequality, segregation indices, and so on. And these are presented as a weighted average. So you're able to, particularly if there are county lines that divide a metropolitan area or an economic area, you're able to select all of the relevant counties and sort of make your own aggregation on the fly. So here's the tech stack powering all of this. So this is all public on our repo on GitHub, which I've linked down below if you are so inclined to check it out. And then we build on Netlify. This is just a standard build command. There are automated containerized scripts that run every day and actually multiple times a day to get that new data and then update the GitHub through a set of CSVs. So all of our data is stored in a few GeoJSONs and CSVs that are served from that production build through a content delivery network. And then those get joined in the browser. We have an API as well, which pulls from copies of the CSVs that are on a separate S3 bucket. In terms of the framework that we're using, the data management, this is a React single-page web app, which is bootstrapped with Create React App. Our state management is done through Redux. We have Redux persist for some persistent settings, although we're still tweaking exactly what that implementation is. And then for fetching our data and loading it up, we just do a simple JavaScript fetch API with D3 autotype to type the data coming in from the CSVs. So for the analysis and the visualization, which is where some of the more novel approaches come in, we're using the WebAssembly or WASM.js Geoda module, which was made by Dr. Xuan Li. And that does the heavy lifting on the binning and the hotspot analysis, everything from building the spatial weights to outputting those results. For the map itself, we're using DeckGL and MapBoxGL for some of the tiled layers on top, mainly the labels and the water boundaries. Our UI library that we're basing most of our components off of is Material UI, and then we're using recharts as a D3 wrapper for those small charts that you saw in the interface. So we've tried, in iterating on the original COVID Atlas, one of the things I wanted to try to accomplish was make it really easy to add new data and new variables, especially because long-term, we'd love this to be something that is easily replicable, something that can be picked up and changed without too much trouble. So the structure for the way the data loads in really is just a folder in the public folder for the GeoJSONs for the CSVs. And then you just feed a config file with the name of what you're looking for. So the name of the CSVs, the name of the GeoJSON, and then the join columns that those should be joined to. And then for time series data, what sort of date format it should expect, so either an ISO date format or the US date format. Additionally, for adding variables, it's much the same. We have essentially a global data function that expects a numerator and a denominator, and you just tell it for each feature that you're looking at, what sort of pieces you should expect. So the data set for the numerator, what type that is, then same for the denominator. So this makes it so all of the calculations, all of these tables are done from a static web server. There's no SQL database pulling these queries. We've found a way to do it relatively performantly. Beyond the COVID Atlas itself, we've also been exploring some platforms to share out the insights. Here, we've been looking a little bit at Observable, which is essentially a sort of a Python or R notebook style data science platform, which is also used for visualization and JavaScript exploration. And so this is really great for doing some mapping and some summary statistics. Here we have a weekly hotspot report that was done by Stephanie on our team, Stephanie Yang. And so here you have a little bit of interaction to look at different states and their hotspots. And you can also pull out the data itself from this table, from this view, and either download it as a CSV or a JSON. The next step for us was to think about, okay, can we embed the whole data analytics process in one of these notebooks using the JS Geoda module? And so what we've now done, we're working on sort of building out exactly what the documentation is and kind of what the presentation is. But right now we have a notebook where you could plug in any GeoJSON and any set of CSVs, join them, and then run a Lisa analysis on the column of your choice, all within the browser, all with no setup required. It's just a site that you would go to, and it's relatively fast as well. There's a big ecosystem on Observable and other similar platforms, but we've started to play around with kind of how much do you need to get these Lisa spatial autocorrelation values. And so the minimum we found is that you can import the utilities from a library that or a page that I wrote. You can call the WebAssembly module, and then again, feed it sort of your GeoJSON and CSVs, and it'll spit back your Lisa values, your natural breaks, and your hinge breaks. So we're playing with exactly what the presentation is on this, how much documentation is necessary, but it's a really exciting way to extend and make these sort of spatial methods more accessible to a wider and to an existing community. Additionally, we've also been in the process of trying to make our data documentation and downloads more accessible. So we have data docs that we're in the process of revamping to be more complete, and also all of our CSVs in our GitHub repository. So for anyone comfortable, you could go and you could download them. But for a lot of people, that may not be accessible if you're in more of a desktop scenario. So recently, and this is hot off the press as of yesterday, we have a data downloader where you can say, okay, I want my case data, death data, vaccination data, and so on, and it'll send you a zip file based on those different data sets that you've selected along with documentation. Additionally, instead of just having markdown files in our GitHub repository, we're pulling those in to really try to have I like the way Catherine D'Ignazio puts it, a biography of the data available, of really what we did, where it's coming from, what does this data mean, particularly for data sets like the mobility data set. This is important to consider. What are the privacy concerns, who is being measured, and so on. So just a few last sort of things, and I'm also happy to walk through anything else, questions or demo after. So this is the mobility data. So this is percent of people who are at home completely. Their devices are never pinged outside home on work days specifically. So here's March 6th in the United States. We can see relatively low, some higher in a few areas along the coast. We can fast forward to April 6th, which in the US was sort of the peak lockdown. We see really strong, a lot of places, over 40% of devices are tagged as never leaving the home on that particular day. Particularly the Northeast, which is at the time where I was very, very quiet. And then we can look sometime in January, and it's a lot of places are the same, particularly looking in the Northeast. A lot of places are still very much people are at home, but a lot of places are not. These maps are also very sensitive, which is interesting. So on this particular day, you can see this swath here, which was likely weather. It was likely, some sort of inclement weather happening there. You can also see, looking down at this area at the border of, this is New Mexico and Texas, a really strong border effect between the two states. And this starts to illustrate how this mobility data has a lot to do with policy decisions, with our schools opened, what is the unemployment benefits available for workers, which businesses are open. So I think this really illustrates the idea of the atlas versus a dashboard. This is really starting to play out some of those different features and contexts, and giving a way to dig into that and try and figure out, okay, what's going on, where was happening, and when. And lastly, and this is still a little bit of a ways out, but we've been playing with some point data here. And so this is just a split screenshot. On the left, you see this is ICU hospital beds scaled in area to the capacity, and then colored based on how highly utilized it is. And then on the right, it's the same data, but presented as a point grid. So you get these sort of miniature charts geolocated roughly to a point cluster. So we've been playing more with other types of data on top of this. Additionally, we've been considering potentially some sort of dot density map to suggest where population density is, and so on. So what's next? As I mentioned, the data layers, we have mobility, essential workers, hospital occupancy, and policy. Visualization modes, these point and point grid views are interesting, potentially population racial dot density, and also expanding that 3D view to have a bivariate z-axis. And then playing more with what is the data delivery and interaction. So these observable notebooks are a very rich platform to share insights. We're thinking about ways that users can load in their own data. We've gotten a lot of requests for zip code or postal code layer data or level data, which at a national scale is not something we could do, but for a user to load in their own data. And then ultimately we want this to be packaged in really easily forkable, remixable templates that someone can pick up, plug in their data, and publish without too much heartache. Yeah, with that, thank you so much. I'll toss it back to Marynia for any closing thoughts.
I will just say thank you to the Robert Wood Johnson Foundation for funding of the Atlas. So imagine there's a gorgeous logo right there of the Robert Wood Johnson Foundation. But thank you guys so much. Sorry we went a little bit over, but I think there's just so many good things to talk about here, and it's been a great team to work with.
Thank you so much. That was a really, really interesting presentation. So thank you both for that. So we do have some time for any questions or comments. If anyone in the audience has something, feel free to use the chat or just unmute yourselves.
Hi, I'm Bob. I'm one of the visiting professors at the lab. Fascinating presentation. Really, really enjoyed it. And it took me a long way back. I did work in the 1970s with our Department of General Practice on the inverse care law. You didn't mention the inverse care law. And if you haven't come across the inverse care law, I suggest that you Google inverse care law, because in the field of public health and general practice, it's the suggestion that medical resources are generally inversely distributed in relation to medical need. And certainly when we were doing work on it in South Manchester, we found that there was a version of it which was that the poorest areas did get the most medical need, but it was completely disproportionate to their medical needs, because their needs were very, very much greater than those of the more privileged areas. So the small extra quantum of help they got was nowhere nearly sufficient to deal with the issues. Also, early in my career, I was producing cancer atlases related to social data, and it is wonderful to see just how far you've taken the technology on from the very, very primitive things that we were doing then. And I think that your COVID Atlas is brilliant. I think it's a really wonderful piece of work. So thank you both very much indeed for your presentation today.
I always appreciate it. I'm very interested in the inverse care law that you're talking about, so thank you. It's interesting how the more things change, the more they stay the same. So absolutely.
I have a question more operational than anything else. So I suppose that, I mean, this is a little bit a bit of a race against time, right? Like as the pandemic is unfolding, you want to respond and you want to sort of do things, and arguably the sky is the limit with everything that you could do. How do you prioritize and how do you decide first? Because I mean, I guess, I don't know, what goes first? And do we really want to make this as a platform for sharing data, for communicating analysis, for enabling folks to do their own analysis? Or this is a tech project to build a package, or all of the above? Or I guess I'm asking this for a friend, so to speak, in the sense that when you have a big project where you could do a million things, but you can only do one, I find it really hard to prioritize. And I'm wondering what your decision process and thinking process was on this space. And thanks very much for the talk. It was awesome.
I'll say maybe something, but Dylan, I'd love to hear what your feedback is too from the other side of this. But I think acknowledging that is a fundamental part of the project on a weekly basis. So that is a constant tension on a weekly basis. And we've definitely, so like at the very beginning of the project, there were the three of us who were kind of the co-PIs, and we decided that we would work through some of these bigger questions on a regular basis, and there had to be kind of a democracy rules kind of thing. That being said, I think part of the pieces were like, what can we offer that other groups can't, right? So we decided early on, so our group is not going to do traditional epidemiological analyses at a city level for every place, because we didn't see that that wasn't necessarily where the need was, but that also wasn't a match with our expertise, right? So I think acknowledging your limitations and what you're good and not good at is really important early on. But the other part was, we decided early on, like, our focus is national. So it's been really hard, for example, in the last few months, hearing, well, a lot of groups want zip code level data. I'm emailed probably weekly for weekly data in Chicago, but I tell folks, like, I'm actually not studying COVID in Chicago. I'm studying COVID at the county level across the US. So I think making a scale decision is really helpful. And then that will have a lot of limitations that come with that. But then, and so that's a big part of it. Over time, we also learned that as our group wanted to get more focused on the analysis, what we were actually hearing, so having a connection to what people want is really important, because what people wanted was not more analysis. They wanted different and better access to the data. So then our group, that was ultimately the most important thing to us, to do what people really need, versus what was good for our careers. I mean, hopefully it'll all work out in the end. But yeah, so that was it. So now we invest a lot more on the communication sides. We hired RAs with arts backgrounds, which was considered, shocking at the time. So I think that having a like the big macro picture, but then weekly follow-ups really helps. And Dylan, I don't know if there's anything else you want to add.
Yeah, I think along the same lines, it's yeah, so we're trying to balance like prioritizing what feedback we're getting and what we're hearing with sort of what is feasible for our team in the short term. And then I think for the tech piece, there is sort of a long-term goal of having these pretty easily accessible templates and repositories we can fork. We're planning on using the same general format with some tweaks for a project about tree coverage and urban forestry in Chicago. So making it a package that we can take and sort of remix for other projects easily, so we don't have to totally start from scratch for everything. We have also, and I didn't talk about this, we've done a few posts on social media, particularly on Reddit, where we get a lot of very spirited conversation. And I think those are useful in highlighting kind of what are the conceptions and misconceptions happening, and what can we do to try to shift that needle slightly towards a clearer and more transparent treatment of the data. So those have been not without their own anxieties produced, but that's also something where, in addition to connecting with our kind of core user groups, with our research coalition, getting general feedback to try to understand where the conversation is. And I think making decisions based on that has been a helpful strategy, just to see what is the temperature at that moment.
There's a question in the chat there. Ellen, feel free to jump in. But she was asking, where does the feedback come from? From public health departments, community groups, other researchers?
So at the very beginning of this project, it was actually connected with a data science group at Wisconsin. So we actually were meeting daily, and then as kind of a research support group during the pandemic. And then that turned into some, like, a number of different relationships. And from there, through those relationships, we would have occasional, bi-weekly meetings with different stakeholders. So one person volunteered to get a group of stakeholders from major hospitals across the country and kind of public health decision makers. Another person volunteered to do that for rural health networks. So we kind of pitched like, hey, this is what we're doing. Is this useful? Is it useless? What information would you need? What's your data wish list? So hospitalizations were at the wish list, at the top of the wish list at the beginning, but we didn't actually get that until December, really. So in lieu of, what's idealized, what's the next best thing? So we kind of continue to build that in throughout. And then also just asking for feedback from a lot of groups. So asking the library group, from your perspective, what's working, what's not working. And then they gave us a report from the communications team from the foundation that we work with. They, everyone gives us a lot of feedback, and users send us feedback. If Dylan changes something, he'll know within a couple hours if it's amenable, because we'll get an email from a user and we respond right away and really incorporate their feedback in response. This is a bit different though. Other projects will be a lot smaller. So like the air quality project I mentioned, we are working with the health department directly, and they're on the grant, right? And moving forward for the next phase, because of a number of different reasons, we're going to be developing, like, formalizing some of the relationships for the Atlas project as kind of a community advisory board, and trying to make sure that we have funding to fund people for their time to give feedback. So that's kind of another component, is if you are asking groups for their, for their assistance and feedback. I think during the pandemic, at the height of it, that was okay because everyone wanted to help. But moving forward, it's going to be important to make sure we actually value, keep our partners, with money for their time. Yeah.
Just on that, what are the next steps? So do you plan on keeping this going past, longer term, incorporating other types of data, pollution data, for example, right? Broader respiratory type stuff?
This is the exciting part. Dylan, do you want to talk about it?
Sure. Yeah, so it's an interesting time for sort of COVID analytics and geospatial COVID analytics in the US, particularly because a lot of the big projects are sort of starting to slow down and archive, particularly things like the COVID tracking project is stopping new data publication sometime next month, I believe. Other sites like rt.live, which is focusing particularly on the RT value, have shut down and deferred to other projects. So this has to do with the Center for Disease Control really starting to step up in more of a coordinated national effort, but there's still a lot of holes. More directly to your question, we have a lot of different data sets that we're excited to add and sort of give a more complete context of what has happened, where and when. Additionally, we're currently proposing this, so not yet confirmed, but we're hoping to add a sort of oral history layer to contextualize not just quantitatively, what do we see in the data, but to really express the experiences of what happened, so that for looking back at the pandemic, when God willing, we're on the other side, there will be a really complete or relatively complete archive of what was experienced and what happened. So, and then beyond that, we have the ambition of sort of packaging this up as a easily usable template, whether that's just a kind of GitHub repository you can use or something even a bit more developed is to be determined. But yeah, that's immediate next steps for the project.
And this goes back to that whole kind of intersectionality concept where we know that people like even after the majority, even after herd immunity is breached, the impacts of COVID are going to be there for a while. And I think, again, the geography focus is more on that. So kind of like, how can we communicate the full story and experience of COVID within the limitations of zeros and ones on the computer. So I think that will be really, we see this as a long-term project in some ways, but the story may change a bit. Right?
It's fascinating. Is there any other questions from the audience before we close out? So just for note, there's some references that were dropped in the chat there, and yeah, Dylan put the websites for all the atlas and all the contact information there. So now that we know that you're checking and you're going to update it, if we send you requests, then I highly recommend that everyone go check out the atlas. I think it's such an important tool, really, really topical, really useful for a lot of people. So thanks again. I think this is a great talk, a really great presentation.
Thank you all.
Great. So yeah, thank you very much. And then unless there's anything out, we'll close out this week's brown bag session. Thank our speakers once again, and keep an eye out on our Twitter feed and whatnot. We'll be publishing the next round of brown bags, and we'll be interested to see what happens with the COVID Atlas going forward.